Good evening, dear Chairman, dear colleagues. I would like to thank the organizing committee for this kind invitation. I will present you a TAVI case from our center. And to start with our case, a 74-year-old female presented to our hospital with progressive dyspnea, BMI of 23. Her comorbidities were hypertension and moderate renal dysfunction. She was on diuretic treatment, and she maintained a sinus rhythm with LV hypertrophy on the ECG. Echocardiography revealed a severe aortic stenosis with an AVA of 0.7 centimeters square, a preserved ejection fraction, mean gradient of 44 millimeters of mercury, and mildly elevated systolic pulmonary artery pressures. Coronary angiography was normal without significant stenosis. And as for the risk evaluation, Euroscore was low to moderate, calculated at 3.4%. And analyzing the CT scan, it was clear that we have to deal with a small aortic annulus. A perimeter derived was calculated at 19.3 millimeters. We can see that we have a tapered configuration of the LVOT with a minimum diameter of 15, no calcium and eccentric morphology. Scrolling up the CT, we can clearly understand that we have to deal with a bicuspid valve with one raphe between the right coronary and the non-coronary cusp, valve type 1 by Sievers, and the diameter at this level intracommissural at 4 millimeters above the annulus was calculated at 20. And on the right side, we can see the perimeter derived at 18.1 millimeters. Further analysis of the CT scan, we have large coronary sinus of Valsalva with an eccentric morphology and moderate calcification on the aortic leaflets. Femoral access was good. Actually, the vessels was adequate, small vessels with mild calcification on the posterior wall, ranges from 5.5 to 6.6 millimeters at the level of the common femoral artery, and the high bifurcation on the right. So the question which raises now is how we can proceed to this young female, 74-year-old with bicuspid anatomy and the small aortic annulus. There are several things that we have to think about it. The risk of the paravalvular leak, because we have to deal with the bicuspid anatomy. The risk of patient prosthesis mismatch due to the small aortic annulus. How we can get the best hemodynamics, future coronary access, the risk of stroke, the risk of permanent pacemaker implantation, and the durability of any of these procedures. Discussing this case to our heart team, we took the decision to proceed with TAVI in accordance with patient's preference. And to start with our planning, we selected the right femoral artery as transfemoral access. Our sizing method was based on the annulus because we have a clear tubular morphology, and our selection was an Evolut Pro Plus small valve 23 millimeter. And this selection was made based on the latest data from the SMART trial, which were presented a few weeks ago, which appears, Evolut platform appears to be superior compared to Sapien in small aortic annulus regarding biprosthetic valve dysfunction through 2 years and regarding hemodynamic parameters. So to go back to our case, this is the first aortography of this bicuspid valve. Crossing the aortic valve wasn't too difficult, and you can appreciate the hemodynamic parameters on the right side with a gradient of 60 millimeters of mercury. We proceed with a pre-dilation with 18 millimeter balloon, rather conservative pre-dilation, no waste of the balloon, good expansion. We advanced the Evolut valve just with a little rotation in order to have the marker hat at the outer curve of the aortic arch in order to achieve the commissural alignment. Our selected view to position the valve was the cusp overlap. Our aim was to achieve a high implantation, 1 to 2 millimeter deep. First attempt wasn't successful, but with the second attempt, we have a good position of the valve. We remove the pigtail, and at the rapid pacing, we deploy the valve. Okay. Final aortography, good expansion of the valve, good position, no paravalvular leak, and you can appreciate the hemodynamics on the right side. At the end, we have to deal with a complication, acute thrombosis of the right iliofemoral artery. This could be probably due to the small vessels and the mild calcification on the posterior wall. Our initial strategy is to use one ProGlide. We give protamine at the end of the TAVI procedure. We close the first ProGlide and we check if there is a need to add something else, one ProGlide or an angiosyl. In this particular case, we added an angiosyl 8 French and we had to manage this complication. Using a Cobra catheter from the contralateral artery, we managed to cross this thrombotic lesion with a Terumo guide wire. We exchanged it with a zip wire, and we continued with repeated predilations with 60mm balloon. And the final result was excellent at the level of the iliofemoral artery and below the superficial femoral artery. The patient was discharged on day 4th with no need for pacemaker. At 1 month, the follow-up was excellent with no paravalvular leak, good valve function, patent femoral arteries. And to conclude, the TAVI can be safely performed in patients with bicuspid aortic valve and small annulus. However, each case requires individualized assessment based on anatomical features and detailed CT analysis. Vascular access complications remain a critical procedural risk, and also we have to care about young TAVI candidates and to think about the long-term management for them. Thank you very much for your attention.
Okay, well, thank you. Can I have a comment?
Yes. First of all, I would like to thank the organized committee, especially Kostas Parias and his colleagues, Michalis, Konstantinos. We're proud to collaborate with this excellent team so many years. 2 questions. Excellent talk. So congratulations. Well, how is the percentage of bicuspid valve who goes to SAVR or TAVI in your center? And
in this particular case or in general?
In general. How is the ideal patient with bicuspid valve to TAVI?
The ideal patient for TAVI, somebody who has bicuspid anatomy, I don't think that exists now. Our first option is to propose the SAVR. But if the patient doesn't want to proceed to a SAVR, we check the analysis to see if we have a favorable anatomical characteristics and to decide if this patient is suitable for a TAVI procedure. These characteristics are the calcification, the distribution of the calcification, if there is an LVOT calcified, a small annulus, yes. We have to check the CT to decide if this is a good candidate for TAVI.
The first question, in general, in your center?
We do a hard team with the cardiac surgeons, yes.
Thank you very much. Congratulations.
Okay, can I ask again the audience who would opt? So let me sum up. We have a small lady with a small anatomy with high functional bicuspid valve. So who would go for a self-expanding, who would go for a balloon expanding, and who would go for a surgery with aortic root dilatation, as I've had some of the organizers, surgeon organizers claim in the media this morning. So let's vote. Self-expanding, balloon expanding, 0, surgery. All the surgeons are outside of the room, I think. Okay, so thank you.
Thank you very much.
We have to go on, despite the